Good afternoon, everyone. Welcome to the Prevention and Early Intervention Subcommittee's third meeting to review its draft report. My name is Mara Madrigal Weiss. My pronouns are she, her, hers, and ella. I chair both the commission and the subcommittee. I am joined online today by Commission and Subcommittee Vice Chair, Commissioner Mayra Alvarez. Mayra, if you'd like to introduce yourself, please.
Thank you, Chair Madrigal Weiss. It's great to be here with everyone. We are all excited for today's conversation as this new year begins. Looking forward to the discussion and making important progress on our shared goals for prevention and early intervention. Thank you.
Thank you, Commissioner Alvarez. Commissioner Alvarez and I also are joined by commission staff who will support the subcommittee during today's meeting. In 2018, guided by Senate Bill 1004, the Commission formed a subcommittee to explore opportunities to enhance prevention and early intervention approaches in mental health. The subcommittee compiled insights from listening sessions and public forums with the latest in data and research to develop a final report, Well and Thriving, which was first released for public review on August 24th, 2022. This report details a conceptual framework including 4 findings and recommendations to instill a shared vision that guides prevention and early intervention in mental health. The subcommittee met on September 7th and again on October 6th last year to review written comments and to hear feedback from the public. Since then, the subcommittee, with the support of commission staff, have worked to integrate this feedback into the draft report. Today is another opportunity to receive feedback on the revised draft report. Once reviewed and approved by the subcommittee, the report will be considered by the full commission for adoption. The subcommittee has also released a draft implementation plan, which details potential steps for the commission to support progress on recommendations from the report. In addition to these actions, the commission's next step is to consider a process for potentially establishing new priorities for programs funded by the Prevention and Early Intervention component of the Mental Health Services Act. The subcommittee welcomes public feedback and discussion on its draft implementation plan during today's meeting. At this time, I will ask commission staff to go over a few housekeeping items.
Thank you, Madam Chair. So I'm going to go over a few general meeting guidelines. To reduce background noise and interruptions, we ask that you please keep yourself muted while not speaking. You can mute and unmute yourself by clicking the microphone icon at the bottom of your screen. And if you're calling in, you can mute and unmute by pressing *6. If you have a comment or question, select the raise hand option under reactions at the bottom of your screen. And if you're calling in, you can raise or lower your hand by dialing *9. Video is encouraged, especially when speaking, but certainly not required. A live meeting transcription or closed captioning is available for anyone participating in the meeting. If that option is not currently visible, please activate the closed captioning feature located in the control bar at the top or bottom of your screen. We also would like you to know that our chat feature is limited throughout the meeting. This is part of our effort to ensure that all participants have equal opportunity to comment, including those not on Zoom. So thank you for your support in creating an inclusive and supportive hybrid meeting space. The chat feature will be available for participants to communicate with commission staff regarding questions about the public review process or technical needs. And you can contact staff by messaging MHS OAC Tech or myself, Kara, in the chat, and we will do your best to assist you. Madam Chair, I hand it back to you.
Thank you, Kara. Now, before we move to public comment, Commission Research Scientist Kaylee Peterson will provide a brief overview of the revised draft report and implementation plan.
Thank you, Madam Chair, and good afternoon. Good afternoon, everyone. Once again, my name is Kaylee Patterson. My pronouns are she, hers. I'm honored to be here today under the leadership of the PEI subcommittee and in partnership with all of you who continue to play an integral role in advancing this important work. Cody, will you advance the first slide, please? So just as a little overview of the report and its findings and recommendations, beginning in 2019, the subcommittee began a years-long process to explore opportunities in prevention and early intervention in mental health. Drawing from the latest in science and insight from community members and experts, this report represents evidence and the urgency for a statewide approach to prevention and early intervention so that California can start to address what some are calling a mental health emergency. The report's key findings show how this emergency has been fueled by entrenched socioeconomic challenges and traumas, disproportionately impacting marginalized communities. Meanwhile, ongoing stigma and the lack of awareness around mental health challenges continue to create barriers to identifying and supporting mental health needs. And limitations in screening and services continue to delay, sometimes preventing healing and recovery for people with mental health challenges. Too often, the consequences of these unmet needs are costly for people, their families, and the communities that support them. Funding earmarked for prevention, early intervention programs is essential for improving these outcomes, especially for those communities who are underserved. Yet funding alone is not enough, and without broader initiatives, statewide barriers such as these will continue to stymie progress. Fortunately, with these great challenges come great opportunities to change the course. Within this report, the subcommittee has identified 4 recommendations to guide this work. For the next slide, please. First, the subcommittee recommends that the state designate a leader for prevention and early intervention, charged with establishing a statewide strategy for prevention and early intervention. As part of this strategic approach, the state must take action to address the current drivers of mental health risk and enhance resiliency for families and society at large. Particular attention must be placed on the prevention of trauma, basic needs, and bolstering the role of environments, cultures, and caregivers in promoting and protecting mental health across the lifespan. The state's plan must also work to promote mental health awareness and combat stigma, ensuring all people have access to information and the resources to support their own or someone else's mental health needs. Finally, the state must guarantee all residents have access to routine behavioral health screening and an adjacent system of care that respects and responds to California's diverse mental health needs. Together, these recommendations present a conceptual framework to guide a shared vision for prevention early intervention, a vision that for too long has been absent in the mental health arena. Next slide, please. Since the initial release of the draft report in August of 2022, the subcommittee has provided multiple opportunities for the public to review and comment on the report. In response to this feedback, the subcommittee, with support from staff, has revised the report to highlight opportunities for prevention and early intervention across the lifespan, with examples pointing to what the state is already doing and how we can work to improve those efforts through collaboration. These revisions bring a sharper focus to the reduction of disparities as a central component to any prevention and early intervention approach, highlighting the use of data and community participation to achieve health equity. Also, these revisions elevate the role of culture to promote as a strategy to promote resilience and support healing, especially among marginalized communities. The report does this by highlighting community-defined evidence practices and other strategies to promote the reduction of disparities. In addition to these areas, these broad revision areas, much of the feedback we received from the public focused on process. Specifically, partners want to know how the Commission intends to implement the report's recommendations. Next slide, please. As a response, the subcommittee directed staff to draft an implementation plan detailing the short and long-term action steps for the Commission to support progress. These actions include, broadly, supporting the formation of a state-level prevention leader, identifying and strengthening identifying new and strengthening existing partnerships that are strategic to prevention and early intervention, both within and outside the mental health system. This plan also includes actions to work with those partners to enhance awareness of the opportunities consistent with the prevention early intervention with an emphasis on equity, diversity, and inclusion. Actions also include the development and documentation of examples of tools and strategies such as fiscal incentives, technical assistance, and research to support implementation of best practices. And finally, to develop metrics, identify opportunities around data systems, and monitor progress of such strategies. Cody, next slide, please. The actions presented in this report and implementation plan together demand significant time, leadership, and investments, yet the result will be a stronger foundation for prevention and early intervention that will benefit Californians now and in generations to come. Your continued participation is critical for ensuring we succeed. We are grateful to be here again with you today and to hear how we can further progress prevention, early intervention for mental health. Thank you, Madam Chair. I hand it back to you.
Thank you. We will now begin our public comment portion of the meeting. Written comments received by the Commission on or before January 13th have been included in the meeting material and posted online at www.mhsoac.ca.gov. You may request a comment by clicking the raise hand icon on your computer or the app, or if by calling in by phone, push *9. When it is your turn to comment, Commission staff will unmute your line and announce your name or the last 3 digits of your telephone number. We will do our best to take comments in order they are received. For this meeting, I have asked Commission staff to facilitate the discussion. For those of you who have presided over meetings, it can be challenging to ensure that all participants have a chance to speak and to manage the queue, to listen to comments and really understand what is being communicated, and to facilitate the dialogue, particularly in a virtual meeting setting. I want to make sure I can focus on listening and really understanding the feedback and guidance you are providing. With that in mind, I have asked Toby to facilitate the discussion with support from Kaylee and Ashley. I, of course, reserve the right to step back in to ask questions for clarification. I so much appreciate your understanding as we work to develop and improve this report. It is now time for members of the public to share feedback about the report. Cody, please open the line for public comment.
Okay, good afternoon. We'll take the hands in the order they were raised. Mary Ann, please begin. Mary Ann, we're not hearing you. You might need to unmute.
I tried to unmute. As some of you may know, I am one of the lawyers who forced the Commission to include relapse prevention for persons who already have severe mental illnesses in the existing regulations during the last go-round on PEI by going to the Office of Administrative Law, which agreed with us that the Mental Health Services Act mandates it. It's something that will be far easier to do if it's necessary to do it again. While I am pleased that this draft report correctly includes tertiary prevention, meaning relapse prevention for persons who already have severe mental illnesses, at page 3 of the report, I am deeply disappointed that there appear to be no further references to it. You need to change that. The last clause of the heart of the PEI provisions that the voters adopted, 5840C, last clause says, and I quote, the PEI program shall also include components similar to programs that have been successful in reducing the duration of untreated severe mental illnesses and assisting people in quickly regaining productive lives, close quote. And because MHSA was adopted by the voters, the legislature did not change it in SB 1004, nor could they. They don't have the power. They have to go back to the voters to do that. They did clarify provisions relating to children, and that is very important. But that has become the emphasis, and unfortunately has created confusion, because in my county, I was told by a so-called county expert on the Mental Health Services Act very emphatically that PEI is only for children. And we all know that it's false. The logical place to address this in the report is at page 23, where there is a mention of CSS, which is the program for the sickest people. As it stands, that mention has nothing to do with PEI. So, why is it even in the report? What it needs to do is remind counties of the mandate that I just quoted, and mandate means it is not optional, for PEI programs for relapse prevention and early intervention in the relapses of persons who already have severe and disabling mental illnesses. I suggest you include some examples. One is AOT, also called Laura's Law, which some counties have, and in its essence, it allows early intervention in relapses of persons who already have severe and disabling and dangerous mental illness, as demonstrated by recent violence or recent repeated hospitalizations. It allows you to intervene before they become dangerous again. Another example would be assertive outpatient treatment, which some counties are doing and calling AOT, which it isn't, but it does follow up on people and try to keep them in their treatment programs. However,
Mary Ann, your 3 minutes are up. Please wrap up. Thanks.
I will wrap up. A third example, there are crisis centers opening all over the state. That is a good thing, but they badly need follow-up for people who have severe mental illnesses. 24 hours is not going to help someone who has a severe mood disorder, even through one crisis, much less for the ones that will come if they don't have relapse prevention. So please amend this report to include the statutorily mandated PEI relapse prevention and early intervention programs that you should be sponsoring. I will send you a copy, Toby, of this, unless I can attach it. Thank you.
All right, thank you, Mary Ann. Next, we have Stacy Hiramoto. Please unmute yourself and you can go ahead.
Thank you. Stacy Hiramoto, Director of REMCO, the Racial and Ethnic Mental Health Disparities Coalition. My pronouns are she, her, hers. Good afternoon, Commissioners Madrigal-Weiss and Alvarez, and a Happy New Year to you. I hope 2023 is a great year for both of you and for the Commission as well. Thank you so much for the opportunity to make public comment on this important topic today. I would like to call attention to the letter that we are grateful was posted on the OAC website with the materials for this meeting. This letter is from REMCO and over 30 other community organizations, as well as the California Behavioral Health Planning Council, and is asking that this subcommittee move and vote to recommend the 2 additions to the PEI priorities to be added to those priorities under section 5840.7 of the Welfare and Institutions Code, according to the authority vested in the Mental Health Services Oversight and Accountability by SB 1004. I believe you're familiar with these 2 recommendations, and others I believe will make comment on them today. A couple things. Although we do not object to the very large plans laid out by your subcommittee for this meeting, we believe it is more important to adopt the recommendations that we have been bringing forth since SB 1004 was passed. After all, there was no such large process undertaken before the priorities in 1004 were instituted. Please adopt our recommendations. Another thing we wish to mention is that although you have had 2 meetings, public meetings prior to this one, and we do appreciate that, we do not see any summary or mention of the public comments that REMCO and many, many others have made at those subcommittee meetings, and hopefully for this one. We do not demand that you take our recommendations, but we do believe it should be noted somewhere that a substantial number of community stakeholders, especially those from racial, ethnic, and LGBTQ+ communities, have asked the subcommittee and commission to adopt our 2 recommendations. Thank you so much.
Thank you so much, Stacy. Next, we have Josefina.
Thank you so much. My name is Josefina Alvarado Mena, and I'm the CEO of Safe Passages, also the chairperson of the Sustainability and Cross-Population Sustainability Steering Committee for the CRDP. Happy New Year, commissioners, and thank you for holding the subcommittee and allowing public comment today. Also, thank you for shepherding the revisions to the PEI report. One, I think, very important thing to consider today and as we move forward is that, although the recommendations are equity focused, they also require a substantial amount of time to be operationalized. And the implementation report or paper does not indicate how any of the recommendations will be operationalized in the future. We respectfully request that this subcommittee and the larger commission take the action that they are authorized to take under the existing legislation to move the needle towards equity now. I have made public comment in numerous meetings related to this topic, and one question that deserves to be answered is which generation of children of color will be the generation to not experience health disparities. Like I've said previously, I would have hoped it would have been my children, but it's not my children. So which generation of children will be the generation to not have to experience these health disparities? As we look at the specific recommendations, they are clearly within the authority of this commission, and they would provide very critical guidance to the local jurisdictions in terms of how they can invest their PEI dollars to address 2 critical areas. The first is focused on making sure that funds can be expended to serve all college-age youth, not just youth that are in college. And the second really gives more clarity around how to address racial and LGBTQ+ disparities that are currently very embedded when it comes to our populations. The language of cultural and linguistic appropriateness or relevance is not enough to move the needle. It's not enough to produce the concrete investment and to shift the paradigm in terms of addressing disparities. And one thing that we know for sure is if we continue to do what we've done over the last 20 years, we will not move the needle. We have had conceptual designs, we have had implementation plans, we have had strategic plans, but we are requesting action today that will make an immediate difference to address the urgent disparities that our communities experience. Thank you.
Thank you, Josefina. Next up, we have Joel. Go ahead and unmute and share your thoughts.
Thank you so much. I just really want to echo the comments of my colleague Josefina and colleague Stacy. My name is Joel Baum. I also am with Safe Passages. I use he and him pronouns. And I'm not going to keep reiterating everything that we've actually been reiterating for months now, including in the letter, except to name just how critical the language is and the requests that are being made with these additions to the priorities. They're not really revisions, they're additions. Do not undo what is being suggested, they simply enhance it. And what is critical with both of those recommendations is they name things, right? They say specifically targeted groups that are underserved will be served, right? When we talk about transition age youth not in college, those tend to be the underserved communities in our neighborhoods, right? Our youth of color, our LGBT youth. When we talk about community designed evidence practices. We're talking about communities contributing to the design of the interventions that are supposedly being directed towards them. There's a saying in many communities, certainly in the LGBTQ and trans community, of nothing about us without us. And it's critical that that language be added to the priorities, because it represents a stance, and a stand that is being taken by the commissioners around this topic. I've had the privilege of meeting with a number of the commissioners to bring these ideas forward. In those conversations, almost universally, it's been like, yeah, that just makes a lot of sense, especially because it's really just strengthening and clarifying. And for our colleagues in the county and others making decisions related to priorities, having language behind them as they make priorities that are not always going to be politically popular, but nonetheless are equity focused, is critical. So I just really want to encourage you to hold a vote that specifically adds those recommendations, or makes those additions to the recommendations. Thank you.
Thank you, Joel. Anne, you are up. Please begin your public comment.
Thank you so much for allowing me to speak. My name is Ann Pinkney. My pronouns are she, her, and hers. I'm the executive director for the Center for Sexuality and Gender Diversity in Bakersfield, California. We are located in Kern County, which folks know is historically a more conservative county. And a lot of times with our population that we specifically serve, which is the LGBTQ plus population, we are oftentimes targets of violence. And I want to support my colleagues who just spoke to strongly uphold and support these recommendations. And the reason why is a personal one. Recently on our staff, we had somebody who was attacked downtown for being a brown trans woman walking around minding her own business. And that is the reality that we face today. And also the reality we face is many of our folks are on the street and are unable to attend school. So they are of college age. So I would really just urge the folks to understand that culturally defined evidence practices, or culturally defined practices, period, are working so much. And that's how we communicate to our community members to try and keep them safe. Even amongst our staff, we see this playing out. So please, we strongly urge you to enhance these amendments, these recommendations, by adding the transition age youth and prioritize community defined practices. Thank you so much for allowing me to speak.
Thank you, Anne. Maya, you are up.
Thank you. Mia Bray, she, her pronouns. I'm also the intern with Remco and a transition age youth myself. And I really just want to support everyone who spoke prior to me. Again, the commission talks a lot about reducing disparities, and the verbiage that we at Remco and CRDP are asking is the verbiage that is to be included as a step in doing so and reducing disparities. So I ask that you please say yes to these two recommendations regarding the inclusion of transition age youth, not in college, as well as community defined evidence practices. Thank you.
Thank you, Mia. Angela Vasquez.
Thanks so much. Hi, everyone. Angela Vasquez, Policy Director over Mental Health at the Children's Partnership. We want to thank the Commission for this opportunity to provide additional feedback on the PEI report. We are deeply appreciative of the work that's gone into developing the report and integrating the feedback thus far. In particular, the inclusion of CDEPs in the report's recommendations is an essential and appreciated upgrade to the Commission's PEI strategy. TCP believes that CDEPs in particular those that are developmentally appropriate and adapted to meet the unique needs of children and youth, are essential to ensuring that the persistent and growing gaps in mental health outcomes are addressed and eliminated for children and youth of color, particularly the alarming growth in youth suicides for Black, Latinx youth, and girls in recent years. We continue to encourage the Commission to continue prioritizing its own investments and strategies in true upstream prevention and early intervention by prioritizing the whole child and social emotional needs of young children and their caregivers. We commend the Commission's intent to better coordinate across the administration, particularly with the Office of the Surgeon General and Health and Human Services, in order to implement the Children and Youth Behavioral Health Initiative, as well as be a thought partner with the administration and advocates on sustaining these historic investments so that we can maintain progress and momentum in reducing disparities in children and youth mental health at the local level. Thank you again, and we look forward to our continued work together.
Okay, thank you, Angela. Rebecca Gonzalez.
Thank you. Rebecca Gonzalez with the National Association of Social Workers California chapter. She, her, hers pronouns. I'm also on the steering committee of REMCO. I'm going to align myself once again with the previous speakers. And I also want to thank the Commission for changes you have made to the report. Looking at the legislation SB 1004, got to put the glasses on here, section 5840.7, where it says on or before January 1st, 2020, the Commission shall establish priorities for the use of prevention and early intervention. These priorities shall include, but are not limited to. So I believe that this really gives the Commission really direct direction that we need to be specific here and really talk about these priorities. This section is where we do talk about targeting youth in college. So I think that now is the appropriate time to expand that to youth not in college, and also the other priority, which you have heard about many times, which is the inclusion of CDEPs. So I think that there's been a lot of great work put into this report. I appreciate the report, but I do believe in order to be consistent and following the letter of the law and legislation, we need specifics. Thank you so much for your time.
Thank you, Rebecca. Dr. Lisa.
Thank you. Thank you, everybody. I'm sorry I didn't realize that the written period was closed. I support everything that REMCO is proposing, but I have a few additional things in looking through the report. One is there is no easy access to ask for help in our state. We do run the California Parent and Youth Helpline, and I find that in the report, there's a lot of big concepts and maybe some examples of some prevention, early intervention programs, but that access point is not addressed. It is really difficult if you are any human being in our state, parent, child, youth, person of color, different lifestyle, different religion, to even reach out and ask for help and not feel blamed and shamed. And we need avenues that aren't run by the government, that are statewide, and we're advocating that include the the California Parent and Youth Helpline, in which you can chat, call, text, or email 12 hours a day, 7 days a week. And it's not large enough to address this idea of prevention at all levels, because people are afraid. They're afraid of being blamed and shamed, discrimination is rampant, et cetera. Secondly, the thing that to me is so ironic is how, if you are a parent or a youth or a senior or anybody, you can't find prevention, early intervention in our state. I asked this of LA County. Where's the list of services? If I'm looking for prevention and early intervention and I want to seek it for myself, for my niece, for my nephew, for my son, whatever, I can't do it because there is no clear listing and there's no demand that the counties list these services so they're easily accessible. It's a total secret across the state what is PE&I services. So how can you affect prevention, early intervention if nobody can find it? Except the provider who has a contract. Seems irrelevant to me. And lastly, we are always promoting that the word support group is listed once in this 124-page report, which to me seems bizarre that it's only mentioned once. And there are no highlights about evidence-based, not just Parents Anonymous, which is an evidence-based support group, which enhances mental health, improves parenting, reduces substance abuse, and ensures child safety in this country, born in California, exists in California. But there are not other support groups even talked about. So I think the big picture ideas, even about equity and justice and inclusion, I agree with Josefina, don't seem implementable because they're just big concepts. And whether you're talking about this generation, as one of the advocates said, or the next generation, it's just an idea. It's like having a statement doesn't make a difference. Only clear action that has results that make a change, because the numbers bear out the discrimination, the alienation, and the poor results that we have in this field. When people say prevention, early intervention, let's invest more, let's invest more. There are programs that have results. We need to look at them. We also need to look at community-directed efforts where communities are saying, this is what we need. Thank you very much.
Thank you, Dr. Lisa. Moving on to phone number that ends in 8433. It's 8433.
Hello?
Hi, we can hear you.
Hello?
We can hear you. Go
Okay.
ahead.
Hi, this is Laurel Ben Hamid. I just got off the train in Sacramento, so I'm in a noisy place, but I just wanted to, as a member of REMCO Steering Committee and representing Muslim American Society Social Services Foundation, which is one of the CRDP contractors with an evidence-based, community evidence-based project, to stand with Stacy and other people from REMCO and community-based organizations today. And I'll be brief. I think I've made comments before, and of course I always point to the refugee community. For example, the 10,000 Afghans who arrived in Sacramento in the last 2 years. Many of those children won't be able to start college right away. They may be helping support parents and siblings. So with their very high risk for PTSD, it just seems to me they're one more example in addition to people who've lived here for centuries and millennia who need to be able to receive services as youth, whether they're in colleges or not. Thank you.
Thank you, Laurel. Moving on to Annie, please go ahead.
Hi, good afternoon, and thank you for this opportunity. Actually, this is my first time I'm even speaking about this in a public forum like this. So thank you. I am from co-founder of Sunrise Special Services. It's a small nonprofit in Lake County, which is a small rural county in Northern California. And I wanted to speak in support of enhancing this cultural defined practice. An example, what I'd like to say is about our journey in even providing services for the communities we serve, specifically for those that are the Latino, the tribal, and other communities of color, especially the church communities. In these communities, when it comes to healing practices, they prefer to not engage in the Western medical model. And we do have success in working with these communities in a more promotoras, community-based models, and working with the communities and linking them to the services. Well, in a small rural community such as ours, we applied for an EPI grant in which we were funded, although it became in question, I believe, because we were in competition from a hospital and a larger agency that their practice is very much the mainstream. And I felt we really were overlooked and therefore overlooked and not funded. So I think we probably are not the only one in this state that's small and really works within their community and understands something outside of your Western medical model of healing. And that's what I just wanted to speak up, and thank you for this opportunity.
Thank you, Annie. Avery, please go ahead.
Thank you so much. Hello, my name is Avery Hulag Vicente. I work with CAMPRO, the California Association of Mental Health Peer-run Organizations. The CAMPRO staff, we identify as peers, myself included. I am a peer consumer. So I want to echo all of the voices that came before me. CAMPRO also signed on to the letter that was provided to the OAC. And the additions that they provide clarity and guidance, just like Joel had mentioned from Safe Passages. I've shared my experience to the individuals in this room in past public comment opportunities, and Chair Madrigal-Weiss and Commissioner Alvarez were at those in those spaces as well. Very briefly, when I was a college student, my life was interrupted by a mental health crisis, and I had to drop out. I dropped out right in the middle of a spring semester, and as you can imagine, a 5150 mental health crisis, coming back from that, bouncing back from that. I'm not ready to go to exams. I'm not ready to get back into studying right away. So college took a huge break for me for a while. And that being said, I would have been one of those individuals who would have missed out on the opportunities that these the opportunities and the programs and the outreach that these PEI priorities will create. I am an example. And so I'm just going to be straight, like, please move forward in solidarity with us and adopt these recommendations. We've been advocating for them for a while. And to Chair Madrigal-Weiss and Commissioner Alvarez, I know that you both value diversity, inclusivity, and access. I've seen the work you've been doing at the OAC meetings, the things that you push for. So don't allow this opportunity to pass. We can move in a direction that is more inclusive and more intentional in the work that will materialize from these PEI priorities. So work in solidarity with us. Thank you so much for your time.
Thank you, Avery. Lueni, please unmute and begin.
Aloha, my name is Lueni Masina. My pronouns are she, her, hers. I am the program coordinator for the Essence Amana, a culturally defined evidence practice under the California Reducing Disparities Project. Thank you so much for this opportunity to speak. Like the previous speakers before me, I also urge the subcommittee to include transition age youth who are not enrolled in college. As we speak on reducing disparities, that includes all. Transition aged youth out of college are no exception and should be made a priority just as much as those who are. Along with the prioritization of youth who are not in college, I also urge that language be added to specify and prioritize community-defined evidence practices. As I stated before, the California Reducing Disparities Project has made CDEPs such as Essence Amana possible to serve underserved and inappropriately served communities, such as the Pacific Islander population, LGBTQ+, and other communities of color. For years, the CRDP has been proven to be effective and wanted by the community. Inclusion of this language will further state policy to reduce disparities for racial, ethnic, LGBTQ+, and other underserved communities. I ask that you please say yes to the recommendations of prioritizing transition age youth and the inclusion of community-defined evidence practice language. Thank you and have a great afternoon.
Great, thank you. That is our last public comment. So I'd turn it back over to the chair or Toby.
Thank you, Cody. I want to thank everybody for their comments here today. And I want to say I appreciate everybody's comments. And I also want to say that, we don't disagree. We agree that these things are important. And just as important, we want to be thoughtful. We want to say that it is important that we create process, as we have heard loud and clear that it's not just about transition age youth in college. It's also about those out of college. And I also agree that CDEPs are an important practice. I have worked in family resource centers. I have worked with the community. I know they're important. And I feel just as strongly that we need a process. We, beyond the letters that we have heard and appreciate, and I love the community engagement, there have been other issues that have been brought up. Homelessness has been brought up. The amount of people that we're losing to fentanyl, to other drug-related issues. So where do and how do we take priority. And so I have to, that keeps coming back to me. And as I stay up at night thinking about this, as I stay up hearing from various groups, and not just in the forms of letter, which I appreciate the advocacy, but hearing every single day in my day-to-day practice and just experiencing this. So I appreciate this. I think that staff have been very receptive to what both myself and Commissioner Alvarez have pushed back on and asked to be more inclusive of. I know this seems like, well, it has gone on for years. So I know it has gone on for years. But we've really want to get this right. So having said that, as I mentioned in my opening statements, we are going to bring the discussion of priorities to the full commission because I think it behooves us to be inclusive of our colleagues. We have a 15 commissioner, I was going to say board, 15 commissioner member commission, and they represent many different partner groups. And I think that it is important that we are inclusive for, not just this subcommittee, but that it become a bigger discussion. So I wanted to say that, but I also want to facilitate more of a dialogue even here. So, and I'm just sharing my initial thoughts with this. I will ask Commissioner Alvarez if she wants to add to that. And then I will ask staff, I will ask Toby to, open up again a dialogue to any of this, to all of this, once Commissioner Alvarez, and if you would like to, Commissioner Alvarez, share, and we will go from there. So again, thank you for being here. Thank you for, sharing with us. Avery, I appreciated those comments. Yes, we want to work in solidarity. Yes, you know what we stand for. And please know that we don't ever stop standing for that. And I just, again, we want to make sure that we're being thoughtful and righteous for all, not just for some, for all. So I hope you hear that, because as much as you feel it, I hope we feel it, and it doesn't ever stop. So let me just say that. So Commissioner Alvarez.
Thank you, Chair Madrigal-Weiss. I also want to start by saying thank you to the many people who have given public comment, not only at today's conversation, but as you've stated, the multiple opportunities for public comment that have been made available over the last few years. The reality is that we have heard time and time again the same comments from the community about what a commitment to eliminating inequities in our mental health system requires. And I just want to acknowledge and thank the advocates that have organized and have brought to the table the many different perspectives from communities of color, from LGBTQ, from my other marginalized communities' perspective. We hear it, we see it, and just really want to extend deep appreciation, whether virtual or in person. You've been there. You've been beating that drum, and again, for my learning journey and my opportunity to use this important privileged position to represent the Attorney General and to serve on this commission. I just want to really extend my deep appreciation for the work that went into bringing forth those perspectives. And to the point of raising this conversation with the full commission, I think this is, again, coming from me, we're ready for that conversation because we are equipped with the voices that so many of you have brought to the table, and the perspective of wanting to advance community-defined evidence practices, wanting to make sure that our efforts to support young people aren't limited to those that are in college. Those are solutions that will impact issues of homelessness that disproportionately impact communities of color. Those will impact the young people that are hit by the fentanyl crisis hardest, because those are disproportionately impacting people of color or marginalized communities or college, non-college enrolled youth. So at least the way I'm understanding the public comment is that both CDEPs and a perspective more broadly towards TAY is integrated into any priority that the commission identifies, that it needs to be prioritized for the way CDEPs are practiced, the way we want to ensure that we're supporting these types of programs. That is what I'm hearing loud and clear. And I want to make sure that we bring that perspective to the full commission. And I think the other part that I think a full commission conversation will allow is, I'm sure there are other conversations happening with our commissioners that may not be part of this discussion section. And I want to be mindful of that. And I'm eager to hear what they have to say. But I feel really grateful to the learning journey that I have been on with many of the advocates in this virtual room and the many, many rooms across the state. And again, grateful for the teachers that we have and excited to ensure that the commission's commitment reflects that. And then the last thing I will say, I just really want to extend deep appreciation to the staff at the commission. There has been numerous iterations of this report. There has been an implementation plan drafted in direct response to wanting to ensure that this report is not a beautiful report that sits on a shelf, but that we actually have actions that demonstrate our commitment to this vision of what a greater emphasis on prevention and early intervention is. So to the extent that that implementation report can be strengthened, can ensure that it serves as a tool for holding the commission accountable to those promises, I look forward to continuing to work with advocates to ensure that those promises are kept. But I just really want to extend deep appreciation to the staff at the commission for being responsive and for working with us to make this commitment really come alive. Thank you.
Thank you, Commissioner Alvarez. And with that, Toby, I'm going to hand it over to you so you can share with us and further open up the dialogue, please.
Thank you, Madam Chair and Madam Vice Chair. So staff's taking notes on all of the comments that have been made. And I just want to step back a little bit and remind that 1004 has several requirements for the commission. It requires us to establish a technical assistance strategy around PEI. It requires us to develop a monitoring strategy around PEI, and it authorizes the commission to identify additional priorities. And we were influential in the priorities piece because we wanted to recognize that the state of our knowledge would evolve beyond the language that was in the statute, and we wanted to be able to promote a more dynamic strategy around prevention early intervention rather than being required to modify the statute every time there was a shift in potential areas of prioritization for PEI based on something like a pandemic, for example. So that third piece, which has been the focus of the public comment, is is a core component. The challenge we have on the third piece is it's in the context of the 7 negative outcomes that are articulated in the Mental Health Services Act itself and in the priorities that were articulated by the governor and the legislature. And thus, in the implementation statement that I believe was shared with this, there's recognition that one of the first things for the subcommittee to do is bring to the full commission this discussion of identifying priorities moving forward. And the message that staff has received from the chair and I think all of the commissioners has been, how do we actually affect change, particularly in these areas of concern around disparities? And so as Vice Chair has pointed out, that it is incumbent upon us to embed a focus on communities of color and communities facing disparities, LGBTQ communities and others, in all of the work that we're doing. This report was really designed to be a framing document or a concept paper that would shape our discussions about how to establish a monitoring strategy. Rather than start with what are the key metrics, we wanted to start with what are the key opportunities. And based on those key opportunities as outlined in the report, be able to then move into the monitoring strategy. And based on those goals, be able to then build out a technical assistance strategy. And there's also language in the statute that indicates that if the commission needs additional resources or if the state needs additional resources, go back to the governor and the legislature to outline that. And so I think you're hearing a receptivity from the commissioners on the priorities that you all have shared, along with us trying to put this in the context of the explicit directives of 1004 broadly defined and the broader strategy that the commission has been able to pursue up to this point but moving forward. So, for example, in the commission's discussions around the limited grant dollars that it has, we've been able to, the direction from the commission has been to focus in the 0 to 5 population, to engage around, and I'll reference Marianne Bernard's comments around relapse prevention. We've made significant investments in rolling out crisis stabilization units that are tied to ER so that we can reduce relapse for those people who are coming into an ER setting, so that they're not moving from an ER setting into a psychiatric hospital, but we can short circuit the time that it takes to move somebody into more stability and recovery. There's a lot of work that's happening. The work that the commission has invested in terms of older adults as well is in direct response to community conversations. You've heard, not today, but in prior public meetings, there have been comments that the report has been less focused on older adults, and it needs to. Our conversations with commissioners, as the chair mentioned, include things like fentanyl, addiction and overdose concerns, certainly working with college age youth, including youth in college, so that youth aren't having to leave college as a consequence of a mental health need, but can be supported to be successful in college, particularly in community colleges, which serve such a vast and diverse percentage of our population. Related to that are opportunities to strengthen this work, particularly around reducing disparities in the Child and Youth Behavioral Health Initiative, in the Mental Health Student Services Act, and the ongoing work in the Mental Health Wellness Act grant funds that we provide. And the last thing I will mention is, as part of the Commission's discussions about enhancing the effectiveness of the work that we do, really seeing how we can more effectively marshal the advocacy dollars that we provide to elevate the voice of the community, consistent with the kind of comments that have been shared today in terms of elevating those voices to shape the kinds of discussions and deliberations that are happening at County Behavioral Health regarding how MHSA dollars are being used. So I think what we're trying to say is that this report is designed to frame out a whole series of opportunities that can shape the Commission's work, but also the work of many partners over the next few years to come, with a focus on doing a better job thinking upstream, working upstream, and intervening earlier and more effectively in the lives of folks who have mental health needs. But I think that the direction from the chair is to have a more open dialogue with people in the room around the opportunity that this report represents, particularly, I would hope, in terms of how to move the priorities in this report forward, including the recognition of community-defined practices and recognition of serving transition age youth who are not college involved. Did I miss anything? No. So with that, I would say, are there additional questions or comments? Dr. Lisa, I saw your hand go up first.
Okay, thank you, Toby. That's great. Implementation is really key. You can have a great idea, a great report. There's a lot of work in here. Implementing and be reality. I just want to get back to monitoring for a minute. This is really directed to the chair and the vice chair and to you. In LA, we have a serious problem. In July, the LA Times reported that $1 billion of PEI money is still sitting there. Even the prior director, Dr. Sharon, told a group of advocates, of which I was one of them, that there was at least 200 million he wanted to get out the door. And I think there's massive confusion as to what the role of the commission is, or everybody pointing the finger. We know as advocates, and it was great that the woman from the rural community said she applied for a grant and up against this and that. We in LA County haven't even seen a bid for nearly 20 years for PEI on the street. So if your role is to monitor what's going on at the county level, That is not, I haven't read the whole report. I think you really need to tighten that up and respond to it. Because what officials in LA say is that it's the state's fault that we can't get the money out. And that money is just accumulating and accumulating. I'm not talking about a general reserve or the other word you use in MHSA. I'm sorry, I'm not, that technical part, I couldn't say I'm an expert on. But I'm telling you, I'll send you the LA Times report, the LA Times article just in July about $1 billion. And Dr. Sharon saying the day before he retired that there was 200 million in MHSA for PEI. If we don't invest in PEI for all developmental levels, for all ages of people, for all, we are not even scratching the surface about why are we collecting these billions of dollars from millionaires who are taxed. If I was a millionaire, I'd be annoyed. Why is my money sitting in the coffers and the county says it can't get it out and it's the state's fault or this fault? So I think that monitoring piece and get the money to the street. I don't think other counties have problems like LA. Maybe they do, but I think the commission needs to take that on because they just blame you or the state.
So thank you for pointing that out. And I'm trying to remember the article. So the commission actually facilitates that level of analysis on our website. We put all of the fiscal reports online so that people like you and the LA Times can see how much counties have in the bank. And we have pushed and pushed and pushed. So our fiscal transparency report gives that breakdown. And so you can see exactly how much money LA County has, and it's over $1 billion. The counties actually argue that not so much the commission as some of the state rules actually impede their ability to spend the dollars quickly. We agree that there are tremendous opportunities to clarify what can and cannot be done with PEI funds. As Marianne Bernard said earlier, someone said, these funds are all for kids. The reality is the rule says 51% or more. So it's not all for youth. And the funds can actually be spent in quite a wide range of ways. There are some very specific things that have to be funded, like access strategies, to your earlier comment, Dr. Lisa. And then there are things that can be done with these funds. The commission adopts regulations on PEI, and if there's some feeling that those regulations need to be revisited, we're happy to consider that. At the moment, though, the kinds of comments that we hear have more to do with the difficulties or the frustration with the kinds of decisions that are being made locally rather than the state rules, with the exception of some of the Medi-Cal billing rules, because there's a 5 to 7 year reconciliation process that can create a fiscal disincentive for counties to spend these dollars in a timely fashion. That really shouldn't apply to the prevention language of PEI, because Medi-Cal typically doesn't pay for prevention. It would apply on the early intervention side, depending on how those dollars are being used. Now, we are very hopeful that the flexibilities that the state is adopting in terms of CalAIM and other reforms happening in Medi-Cal, including things like the dyadic benefits, will actually free up more opportunities for counties to be assertive and aggressive in how they spend these funds. And just to be clear, the commission is an oversight body, but we're primarily an advisory body. What the law says is that if we identify a concern, that we are to alert the Department of Healthcare Services what that concern is, and Department of Healthcare Services is the investigatory body. They have audit authority, the commission does not. We are more like a mental health grand jury, in that we draw attention to an issue, put it on the table, and encourage the governor and the legislature to intervene. And so we have been doing that consistently for the past 7 years in terms of the unspent funds. I will share that over the past 3 or 4 years, there have been a number of discussions about potential MHSA reforms that have circulated. I think the pandemic has really suspended those conversations because people have been so focused on the immediate needs of the pandemic. But there may be a willingness among the governor and the legislature to revisit some of the rules, particularly rules about unspent funds. And thank you for clarifying that this is this sort of cash flow reserve, not the prudent reserve, which has some restrictions that you're talking about. I hope that's responsive. Keep looking at that site. The latest batch of fiscal reports will come to the state in February. And so we will get them online as fast as we can. We anticipate that we may see an uptick in unspent funds as a consequence of the pandemic and difficulties that counties had in spending dollars. We would be more receptive to seeing a decline in unspent funds, which would reflect an acceleration of spending in response to the dramatic increase in needs that happened during the pandemic. But we won't actually know until we get those reports in February. Thank you, Dr. Lisa. Josefina, I saw your hand up next.
Thank you, Toby. And thank you and the commissioners for your thoughtful response to the public comment that was provided earlier. There was a question that you posed to the group today, and that was how to affect change. And I wanted to try to answer that question, at least based on my own experience. And so I think affecting change absolutely requires concrete action. And that's been the focus of the conversation today, the focus of much of the public comment over the last several months on this particular topic. It also requires that we enlist the support of the community and the local county jurisdictions. And I think there's a question that we struggle with a lot, and that is how do we go beyond piloting for those programs and strategies that work in terms of reducing disparities? And part of the way that how we get beyond piloting is that we open up for the investment in what works for communities of color and LGBTQ+ communities. And because of structural factors that reinforce inequity, it's often impossible, are very, very difficult to be able to do that. I understand, what you're saying in terms of the commission, the role of the commission, and often the commission acts like a grand jury, which is very much after the fact of something happens, it didn't happen appropriately, and then the grand jury comes back and issues a report. But in terms of the responsibility related to setting the PEI priorities, the commission is not in the grand jury position. The commission is in the providing guidance before the action happens position. And from that position, you are able, and it is within the authority of the commission, to make it clear that PEI funding can be used to fund programs and strategies like CDEPs that work for communities of color and LGBTQ+ communities. And that's what we're asking you to do. And these recommendations that we've put forward in no way prohibit the commission from taking any other action to address any other need in the state. We're not asking you to pick and choose which disparities you want to prioritize. We're asking you to make these changes now to affect the change that is in your mandate, in your own strategic plan. And I wanted to read something from the National Institute of Health, because I think it speaks to exactly what we're talking about. And here's the language. Despite longstanding investment to reduce and eliminate health disparities, racial and ethnic minority populations that experience health continue to bear a disproportionate burden of adverse health outcomes across diseases and conditions. Health disparities are longstanding and deeply rooted in structures, systems, and policies. That's what we're talking about today, that create social and economic advantage and disadvantage, limiting the optimization of health for racial and ethnic groups and other populations experiencing health disparities. These reinforcing and inequitable systems are the fundamental causes of poor and different health outcomes, and thus must be addressed to make observable and sustained improvements in health. Ultimately, a paradigm shift to advance health equity is required. In the absence of this, we will continue to fall short in eliminating health disparities and creating a healthier nation for all. Addressing fundamental structural causes of health disparities offers the greatest opportunity to advance health equity and eliminate health disparities. This is what we're talking about. It may not seem like a huge issue, but changing augmenting the priorities to make it very clear that this funding can support what works for the communities that we represent would make a huge difference. It's not a mandate to local jurisdictions, but it's powerful guidance that will make a difference and affect change. That's what we're asking for. And we're hoping that this committee will meet this moment and seize this opportunity, like the Cultural Linguistic Competency Committee and like the Client and Family Leadership Committee, endorse the recommendations as the conversation moves to the full commission. Thank you.
Thank you, Jose. Thank you, Josefina. Sorry, we're dealing with, okay. There was a lot in there. I appreciate you kind of focusing in but also stepping back and giving the bigger picture. The framework for this report is very much about that your final point about how addressing disparities will require us to think differently, to that we cannot address the kinds of health challenges we have in our communities through a more responsive healthcare delivery system, that we have to look upstream at social determinants of health, which is why this report focuses on creating economic opportunities and supporting education and looking at land use planning and all of these these systemic drivers that lead to the kinds of disparities that are on the table today, including trauma and racism and bias and prejudice that are endemic in all of the systems that we're talking about. And so the commission has been doing a number of things, including the support that we provide to elevate the voice of diverse communities. We think that's a foundational investment that we make, and it's key to making sure that the decisions around mental health that are being made, which are primarily at the county level, are informed by the community voices that those services are intended to support. And we have made investments through a partnership with Solano County and the Center for Reducing Health Disparities. We have 40 counties that are all learning together around ways to elevate the voice of diverse communities, targeting the populations that have the greatest level of disparities in their community. And so, again, I just want to respond to your comment about this is really about how do we be as effective as we can, as fast as we can. And so, much of this work is actually already started. And your point about how do we scale is something that we think about every day. And I think, as you know, and that's part of the reason behind the comments, is it's very hard to scale programs if it's not easy to pay for those programs. So the work that we've been doing on youth drop-in services, the work that we're doing around school mental health, we're making significant investments to make sure that the funds that the state has provided, which are a limited term in nature, actually create new financing strategies so that those programs can be sustainable. And that's at the core of the advice and guidance that we're giving to the legislature. In terms of your first comment about, yes, in this instance, we are not serving as a grand jury, right? We're not writing we're not giving advice to the governor and the legislature. As you pointed out, the commission does have the authority to identify priorities. First, I just want to caveat that to say that the commission's identification of priorities is itself advisory to the counties. Ultimately, it is up to the counties to decide how to spend these dollars. And any priority that the commission were to adopt, any priority that the legislature adopts under the structure of 1004 is purely advisory. And so what we really are trying to do is to facilitate the kinds of conversations where counties can do this work. They can do it today. They don't need that language from the commission, and it's unclear how influential that will be if, to your point, if it's simply a report or if it's simply a statement. What we really want to work through with the full commission, I think that's the direction from the subcommittee chair, who at the moment happens to be the chair of the full commission, is how do we roll up our sleeves and really drive the kinds of change that you and Remco and others are looking for in terms of reducing disparities. But it does require going to the full commission because it impacts the kinds of, appropriately, a higher level of resources than staff can do on their own. And so fortunately, we do have the $429 million that the governor and the legislature allocated through the the Child and Youth Behavioral Health Initiative to scale evidence-based practices and community-defined evidence practices. We're working with DHCS to understand what those opportunities are. We're supporting them in their rollout. 10% of those funds do come to the Commission for technical assistance. We're working with them to identify what the parameters are to use those funds. And again, we also have this tremendous opportunity through the Mental Health Student Services Act, because schools they are such an important community center for so many families, particularly through the lens of prevention. We recognize that the K-12 system doesn't address the needs of so many transition age youth who are, post high school, but CYBHI goes beyond the high school age as well. I think it goes to age 25. So I don't think we disagree with anything you're saying at all. It just takes us some time to get through the process to adopt this, to write this report, get feedback, adopt this report at the subcommittee, take it to the full commission, and then also engage in some of the awareness work that has to happen. Some of our commissioners are new, and we need to frame out the statutory, the initiative requirements of PEI, the statutory requirements of PEI, and the opportunities for establishing new priorities. I will share with you that several of the commissioners have shared with me and our team that they wish we had key data points that they could point to try to determine how to prioritize. Although you said this isn't about picking one priority over, one topic over another. In fact, that is what it entails. And so it is very difficult to say that more time should be spent on one need and less time on something like the fentanyl crisis. And so they have asked us if we could bring together actionable, valid, and reliable data to help them frame out those trade-offs. And that's very difficult to do, as evidenced in this report, calling for better data analytics around how the dollars are being spent today, which gets to Dr. Lisa's point. I think some of the comments that you have made here and in the past. And if we're going to make new investments, we're going to shift dollars from existing programs to new programs, what rationale do we use to make those decisions? Those are very difficult decisions.
I'd just like to be very clear that, all
Go
of
ahead,
that.
Christina.
Thank you. I just want to be very clear that we are asking for a specific action here. And that does not take away from any of the other work that you just described. But I think there's clear indication, and that has been well established, that we believe augmenting the priorities with the recommendations would significantly move the needle. And that's the request. So I don't want that to get lost, in terms of, all the other work that's described, because there's also opportunity here. And I know that it does not come along very often, and this would make a significant difference. So I do not want that to get lost in the larger kind of discussion about, everything else that's going on, because we've also had 20 years of the MHSA, and the disparities have not been reduced. So we have to be able to kind of step outside of our comfort zone and seize the opportunities when we have them. And that's what we're asking for.
I think you've been very clear. You absolutely, and we appreciate that. Stacy.
Thank you. The SB 1004 was passed in 2018, and this commission has had meetings, and I assumed was collecting data and was listening to community voices. It is now 2023. Again, pardon me if I'm just puzzled why we have to go through more process to find out what reduces disparities, what can be done to reduce disparities and serve racial, ethnic, and LGBTQ and other underserved communities, including the consumer community, immediately. I think it's really, again, you've taken 3 years to write this report, and now you want to do yet another process, which, although we don't oppose, we are telling you, the community are telling you now what you can do now to immediately address reducing disparities. I think it's extremely important that you both, that you know and acknowledge that the County Behavioral Health Directors Association supports our asks, our recommendations, because again, it provides guidance. Yes, we know, Toby, that the decisions are made at the local level, but they must start with the priorities in statute and as a starting place. And this guidance from the county that we are asking would provide a real boost for, again, reducing disparities and preventing discrimination against youth who are not in college. How many times do I need to say who is disproportionately not in college? Black, brown, and other underserved, foster youth, those youth. To me, that's a no-brainer. That's a no-brainer. And then again, as far as the CDEPs, again, as Josefina said, it's not a mandate, but it gives a leg up. It gives the counties the opportunity to say, we need to take a look at this. And the last thing I really want to say is, I feel bad because I know you're tired of hearing from me. I don't blame you. but I've brought so many wonderful, hardworking people from local jurisdictions, which you guys seem to value above the state voice. I've brought these folks to the committee, and I almost tell them, don't say you're associated with REMCO, because I feel like you're like, well, anyway, these folks work directly with their communities at the local level. And I feel like in your report, and there is nowhere, for example, today, the vast majority of these people were from community-based organizations serving underserved communities, and they were taking time off from their jobs to weigh in here because they think what we're asking for is important. And so again, I keep wondering, well, you keep going, well, we don't want to hear just from you. And I don't know who you mean. I know you're tired of hearing from just me, but it isn't just me. And I try to make it aware that I am speaking on behalf of many people from the local level, not the state, the local, from underserved communities that want what we've asked you now for since 2018. And again, please don't tell me that we have to collect, we have people in the underserved communities in school. How much data do we have to collect to keep proving once and once again that there are disparities and they are not being reduced right now? And yet we are telling you two easy things. People keep asking me, why don't they just adopt this? What's the big deal? And I do not know what to tell them. So I'm sorry if I went off, but again, we don't often get this chance to dialogue. So thank you.
I appreciate that, Stacy. So we don't tire of hearing from you. We appreciate, I mean, I think you and I've had a number of one-on-one conversations over the last few years about the sort of the state level voice versus the community level voice and how important it is to have both. And so, we appreciate and see all the payoff of the energy that you and others have put in. It's nice to see Joel at Safe Passages now. It's nice to connect with more and more voices, folks who are working in Lake County and Kern County, right? That really does, lend to the power of that voice, because it is a statewide voice. It isn't just a Sacramento state level voice, but a statewide voice. And so, I personally, and I think on behalf of the commission, strongly encourage you to keep it up. right? It's not that we get tired of hearing it. It's that the commission is a multi-member body that has to go through a process. We have to operate in public. There's work that has to get done, and it doesn't always happen very quickly. We did not intend this work to take as long as it has taken. Per your comment, nobody's more tired of this work than we are, in terms of Kaylee and Ashley and our team that have just been, phenomenal in terms of bringing together all of this work. We've heard from, I want to say thousands of people, but it might be better to say many, many hundreds of people through the process that you have seen, but also through site visits and sidebar conversations that have happened just at the staff level. We're working to actually create a map to show all the community engagement that happens, because that is important to us, and the voices that you help bring, including today, to this forum is really helpful. So we never want to discourage that at all. In terms of why don't they just adopt these, right? What we're really focused on, and what the commission is, the chair has shared with me, is really getting at how do we reduce disparities. And so the conversation I think the commissioners need to have is, what will it take to reduce disparities, which is what you're saying, what Josefina is saying, and others, right? And it's not clear that the mechanism is as simple as saying, pick this as a priority. The language of 1004 around college age youth doesn't actually say ignore students who aren't in college, or college age who aren't students. Pardon me, didn't say that right. What it says is prioritize all youth. And within that priority, prioritize college-based programs. So there's some nuance in there. The very first priority is all youth, high school and college age, right? It does then say, within that priority, a priority for college-based programs. And so what does that look like? Your comment that CBHDA, that county behavioral health directors are fully supportive of these priorities, yet the trigger is that the commission needs to adopt it so that they will actually do it. That's a little bit challenging for us, right? They're asking us to tell them what to do. And so what we really want to understand is what would be effective. If we adopt those priorities, will it make the immediate difference that you're looking for? We're not so clear that that is the case, because to your point, Josefina's point, Dr. Lisa's point, and others, counties today can use PEI dollars for community-defined evidence practices, but it's not clear that they are. And so part of this, the important piece here for us as commission staff, as we go to work every day, is what do we do on a day-to-day basis to actually make the work in this report be meaningful in such a way that it does result in the programmatic changes that the community needs to address disparities. So for example, one of the conversations I've had with one of the commissioners is, should the priority be on disparities as the goal, recognizing that it is already a requirement of the MHSA, but it's unclear that county MHSA plans are elevating disparities with the level of urgency that they should. So again, apologize effusively and the amount of time this has taken. I'd be happy to sit down with you at another time and lay out all of the things that the commission did during the pandemic that delayed some of this work, including pushing out emergency resources for suicide prevention and social emotional learning and strength. We work directly with FEMA, lots and lots of delays. And we regret that as much as you do. But again, this dialogue, happy, Stacy, if you want to follow up with that or move to Joel.
Move to Joel.
Hey, thanks. It's nice to see you, Toby. Yeah, I just want to kind of speak to this, the comment that you mentioned that commissioners are asking for data, right? And they want data that shows what's effective. And I want to zero in on the CDEPs as not business as usual, right? And so the CDEPs provide us an opportunity to, in fact, shift the paradigm, right? The NIH, in the quote that Josefina shared, is in fact really looking to move the conversation from business as usual to one that says, look, we need to look to the communities themselves. And the language, right? Community defined evidence practices. It's amazing how important a hyphen is in a name, right? Community defined, not traditional, not saying that there isn't room for all of the evidence-based practices that have, for years and years and years, decades, not really moved us that far along. Those we'll continue to do those, I'm sure. That's not the issue. But how do we, in fact, change the paradigm so that those commissioners, in fact, themselves are saying, but whose evidence is this? And who says this is the evidence that matters? At one point, I thought I heard you say, we're only advisory, right? We don't tell the counties what to do. We can only advise them. But in the absence of language, that speaks volumes too. And so I think just the ability to explicitly name the CDEPs, explicitly name those, because it does say all youth, yes, and then the college, then it's by exclusion, not naming those kids not in college. I think that, again, connect to my original point, the power of very specific language creates cover for those county agencies and others to have courage. And sometimes they need the coverage from above. Right. Well, MHSOAC says it's okay for us to do this, so we're going to push the envelope. We're going to, do this non-traditional, quote unquote, non-traditional approach because there's language that says we should and that it's time to do so. And so I again hear what you're saying, and why wouldn't you just do it? It makes so much sense. And some of the pushback, I feel like we have to be able to push back on that pushback and say, well, here's why. Here's why, because it hasn't been working. And we are now explicitly naming a couple things that we think have real potential. Thanks.
Thank you, Joel. We don't actually think it is pushback. We think it's, actually kind of dialogue, right? And informing this. Just to clarify, the data wasn't so much about in my comments around the data with regard to PEI is, lamenting the fact that it's very difficult to look at sort of the universe of opportunities and to be able to weigh trade-offs, right? In terms of how that's right. So it's not that we don't have data on disparities. Disparities are very well documented. What we have is gaps in the knowledge around what should the area of focus be in terms of a programmatic, right? How to respond. And so it isn't disparities versus not disparities, right? It isn't even, community A versus community B within the disparities space, right? It's more of, fentanyl versus homelessness versus child welfare involvement. And just to complicate this or to express some of the complication a little bit more, there are 7 negative outcomes in the original initiative for PEI, reducing child welfare involvement and justice involvement and school failure and unemployment, homelessness. And there are, dramatic disparities in each of those. Those are mandates, but by the voters that go back to the origins of the MHSA. We have struggled to document how counties are responding to those opportunities at the moment. The commission spent a ton of staff time and money to build a program reporting tool that allowed people to just do a word search. So you could see how PEI dollars are being used in given counties and how much and who the target population was. It was very labor intensive. And by the time we finished the database, the data were no longer valid because county programs changed. And so we found it wasn't cost effective to sustain it. But we have been talking with counties about trying to come up with a much better reporting system, including piggybacking on the MHSA 3-year and annual update planning requirements, so that the report that got submitted to the state, rather than us retype it all, that it would just facilitate that database. And then that would allow the commission, but more importantly, the local community to see the kinds of priorities that counties were investing in, and even be able to compare County A to County B, so that we could really facilitate cross-county learning and the kind of scaling that Josefina talked about is when we've got something that works, let's scale it, right? So that the commission could focus on creating the policy, fiscal, workforce, licensing, and those kinds of environments that either facilitate scaling or don't. In terms of the advisory piece, the commission has multiple hats here, right? We are a grant maker, we are a regulator, we are an advisor. My comment there was that the counties at their discretion can set aside the 1004 priorities. And so, I think what my bosses really, what they talk to me about all the time and our entire team is what's actually going to be effective. And so that's why I shared some of the comments about the things that we're already doing in terms of trying to tackle some of these challenges. Marianne Bernard talked about relapse prevention. I mentioned our hospital-based empath programs. We have new requirements to focusing on strengthening full service partnerships. There is all the school mental health. We did this documentary with Ken Burns to elevate the youth mental health crisis, and there's more work happening there to disseminate that information through schools and other local partners. And so, there are a lot of things that we can do, and we're trying to be very directed and very strategic, and to have the kind of impact that you're calling for. One of the questions that we're asking ourselves that may be the most important action that the commission could take is simply to remind county behavioral health directors, county supervisors, local mental health boards, and the broader community that around the level of flexibility that is available under PEI dollars, what can and cannot be paid for, and to clarify that community-defined evidence practices are eligible for PEI funding today. And so if the issue is, as has been shared in this forum, that county behavioral health directors want to do this, but they need some permission, is the permission simply that it is legal? Or is, we can clearly do that. And so, that's some of the dialogue that we need to have with the commission and with the counties around how we can, what is the most effective action the commission can take? Because like you, commissioners are frustrated, they're tired, it's been too long, and they want us to bring urgency to this. Thanks for being here, Joel. Appreciate your comments. Josefina, I think you.
Yeah, thank you. I just wanted to, bring us back to again, in terms of how do we scale what works. A big part of that is making sure that there is funding to support scale. And it's not just a particular focus on one funding source. It's a focus on many funding sources and diverse funding sources. And PEI funding is one funding source that is absolutely applicable to what we're talking about. And the recommendations that we're suggesting would provide guidance that this is a funding source that can be used to scale what works for the communities that we're talking about. And in the context of the 7 areas that you mentioned that are written into the legislation, every single one of those priority areas or areas of focus can be addressed through the PEI funding strategies. So I think we're absolutely aligned with the legislation, with the authority of the commission, with the strategic plan of the commission. And I know you probably can recite it verbatim, but if you look at strategy goal number 1, that talks about the commission will advance a shared vision for reducing the consequences of mental health needs and improving well-being, and promote the strategies, capacities, and commitment required to realize the vision. What we're talking about absolutely is in line with that objective. And specifically, there's language that says, as directed in SB 1004, distill and disseminate knowledge on how mental health issues can be prevented, detected early, and addressed at population scale. We're talking about that. Communicate the potential to prevent mental health issues to public and private sector decision makers. We're talking about that. And in strategic goal number 3, to identify additional opportunities for continuous improvement and transformational.
You went on mute, Josefina.
augmenting the PEI priorities like we've recommended would absolutely accomplish those goals of the OAC strategic plan. So I think there is alignment with the action that we're talking about. And nothing that I've heard today really prevents the commission from doing what's been recommended.
I appreciate that. And I think you've heard from the chair and our vice chair that there's a tremendous alignment between what you're saying and the goals that the commission is trying to achieve. You know, we just, what we haven't done yet is actually put that in front of the full commission for a discussion. And so one of the ways when we have new commissioners and new staff, and we talk with them about the reality of a multi-member body, is everybody comes to the table with a different set of experiences and perspectives. And it's really important to create a process where it facilitates shared understanding that leads to the kind of dialogue and deliberations that support collaborative decision making. And so we've got, again, I'm not trying to say it's going to take us another 3 years. We haven't had those conversations with the full commission yet. And we want to have them in the context of the report that's in front of you. Today's meeting is actually about the subcommittee adopting this draft report and passing a motion to transmit it to the full commission. This subcommittee is an advisory entity of the full commission. And so there's a procedural process that we have to go through. That procedural process is essential as a public body. And that's what the conversation is today. But I agree, Josefina. I don't think anybody here has ever raised objections to the goals that the community has raised. Our concerns have more been about timing, to be frank.
I mean, I would
see any other hands.
So I was just, Nani has her hand up, but in just really brief response, I think the timing is now. And we specifically are requesting that Commissioner Alvarez make a motion to add our recommendations to the PEI report as it's forwarded to the full commission, and that both commissioners adopt that, approve that as it moves forward. Like the other subcommittees that I mentioned before, the Cultural and Linguistic Competency Committee and the Client and Family Leadership Committee, that this committee formally adopt our recommendations and add them to the report to the full commission. Thank you.
Thank you, Josefina. Is it Nani or Nanny?
It's Nani, and thank you very much, Toby. And thank you, Josefina, actually, because your ending was actually the intro to the importance of timing. You know, everything that's been said today is so crucial and so important. And the time is now in regarding these recommendations, because it's a matter of life or death. Someone who is appreciating every moment that gets to breathe life as myself is seeing people who are falling through the cracks. And it's our responsibility as human beings to be able to step up and get this moving, because otherwise we are going to go in circles and circles and circles. We have to be those warriors for those who don't have a voice, to be able to create an open space so that we can go ahead and move forward on this. And so I just want to say thank you to all of you who have spoken today and sharing your courage and your strength. And, you know, we understand how important it is to make sure to critique everything, to get it right, but we need to move forward because we on the ground are seeing people losing their lives. And that's the whole purpose we're here. And I just wanted to bring it back to that. Thank you very much for that time.
Thank you.
Okay, I see no other comments. Yeah, see no other comments. Okay. I have been listening in and appreciate everything that has been said here this afternoon. Stacy, I heard what you said. I think everybody should identify with Remco. Every time you speak, I learn something, and all those that you bring together with you, it is important for us to keep learning, for me to keep learning. And I just want to be really clear with something. My plan as the chair of this subcommittee is to bring this forward. We are meeting as a full committee in 14 days. Full commission, I'm sorry, full commission in 14 days. I don't know, on the 25th and 26th of this month. And my plan is to bring this conversation to the full commission. I want to be clear once again. We agree with the importance of CDEPs. We also agree with the importance of the inclusion of communication around, it's not just TAY youth and college. I also want to be really clear that throughout this process, as an educational administrator, as a social worker, as somebody who's been dedicated to the human services field, what I keep going back to is accountability and data informed decision-making. When I keep going back to the question of, asking staff, where are we with the 7 negative outcomes that we're supposed to be addressing with PEI, and we can't answer that. When we can't even have information on the existing priorities, and then to add additional priorities, which I agree are very important, it's important that we also have process. So having said that, I want to have a conversation with all the commissioners and again, agree that the conversation around additional priorities is important, and agree that is an important conversation to have with all the commissioners. So with that, I am going to move forward with the vote to move this report. Please give me the right wording to move this report. I need the correct wording, please.
Recommend that the commission consider adoption.
I recommend
Commissioner, I'm here to help
the
if you need
commission
me.
consider adoption of this report.
Can I ask one question?
Yeah.
Where does the implementation plan fall in the adoption of the report? Is it one and the same?
No, it's a supporting document.
It's a supporting
A
document.
supporting document because it's a living document. So it's something that can be added to, because we didn't want it to sit as just here it is done. It's a living document that can be added to with additional discussion.
Okay. In our implementation report, do we include an action to revisit the priorities? The actual priorities?
In the implementation.
In the implementation plan, yeah. As a implementation plan reflects the vision of the report, does our implementation plan
In the
say?
beginning of the implementation plan, there is potential for the commission to consider priorities.
Okay, great.
It's in the very, as like the very first one.
Great, fantastic. So I think that is the opportunity through which we would engage the full commission in identifying those priorities, including ensuring that emphasis on TAY does not only include those that are college enrolled, and a prioritization of community-defined evidence practices.
Yes.
I said that out loud for the record.
You did.
Okay,
You did for the record.
Is there a motion?
you moved.
She made the motion.
I motion.
Oh, I'm sorry. I move. I so moved.
I second.
Okay.
All the,
So.
Okay. Okay, let me help here a little bit.
Sorry.
Okay, so there is a motion to forward the draft report to the full commission for consideration. And there's recognition that there is an implementation plan sort of as an affiliated document that says first step is to discuss priorities in PEI.
yes.
So with a motion, a first and a second, I will call the roll. Madam Chair,
Aye.
Commissioner Alvarez. All right, so the motion passes, and so staff will then forward the draft to the full commission, and we will work to put this on the full commission's agenda, including an opportunity to identify priorities and discuss those with commissioners. The soonest we could do that would be the February meeting. But it may actually be March, as we have to work out the calendar in terms of the commission's schedule.
No later than.
No later than March.
Okay. Thank you so much, everyone, for being here. We greatly appreciate it. We will make sure that this works for all of us. That is what we are here for. I want to thank Commissioner Alvarez for being here, all the staff, of course, the community members. Thank you for being here. We appreciate your time. We hope you have a wonderful and safe afternoon today. Take good care of yourselves.
Thank you.